Welcome, everyone. I think we'll get started. Thank you for joining us today. My name is Jillian McConnell, and I'm the Knowledge Mobilization Lead with Brain Exchange. This webinar we're proud to be hosting is part of a knowledge dissemination series offered in partnership by the Brain Exchange and the Alzheimer's Society of Canada and the Canadian Consortium on Neurodegeneration and Aging, also known as the CCNA. So before I go into the typical housekeeping items I review before each and every webinar, I do want to recognize that this continues to be a challenging time for our country, and the demands on all of us, personally and professionally, has certainly increased. So we do thank you for being here, and we thank you for all that you do. Okay, so those housekeeping items. The audio is provided over the phone, which means if you're hearing my voice, you're all set. The visuals or the slides are provided by the online link that you would have received in the connection details, and that way you can watch the slides as our presenter speaks. On the bottom left of the screen, you'll see a little blue bubble. If you move your cursor or your mouse over that, you will see chat with the presenter, and click on that and the chat pod should appear. And that's how you can communicate with me during the event as well as the presenters. I do want to note that only the presenters and I can see your notes in the chat pod, not your fellow participants. And that's also where you can send your questions during the Q&A. So as per usual, all of your lines have been muted for the time being. That just helps us minimize background noise or any private conversations, codes going off, dogs barking, etc. If you do need to ask a question or have a concern during the actual presentation, then please use the chat pod, as of course we can't hear you. So the presentation itself is being recorded, and I'm going to do my best to try to get this recording up as soon as possible because of the topic at hand is obviously close to what we're dealing with today, and there's been a lot of interest, and I also wanted to get it up before the holiday. So we do encourage you to pass that link on to any colleagues who weren't able to join us today. So for the purpose of this afternoon, those are really the only features you need to be familiar with. The webinar will be 60 minutes in length, and our presenters will speak for about 40 minutes or so in total, and then we'll have the last remaining 15 minutes or so at the end for some Q&A. I do ask that you refrain from asking questions in the chat pod until the end of the presentation portion, unless, of course, it's technology related, and then I'll do my best to help you out as quickly as I can. So now that the technical aspects have been taken care of, I want to, or it's my pleasure actually, to introduce our topic and our presenters. So the title of today's session is COVID-19 infection in persons living with dementia, and it features two presenters today, Drs. Julie Robillard and Dr. Eric Smith. So Dr. Robillard is an assistant professor of neurology at the University of British Columbia, a scientist in patient experience at BC Children's and Women's Hospital, and director of neuroscience engagement and smart tech, also known as NEST Lab. She is chair of the Ethical, Legal, Social Impacts Committee of the Canadian Consortium on Neurodegeneration and Aging, vice chair of the Technology and Dementia Executive Committee on the International Society to Advance Alzheimer's Research and Treatments, and a member of the board of directors of the Medical Device Development Center of British Columbia. Dr. Robillard brings multidisciplinary background in neuroscience and biomedical ethics to the study of issues the intersection of aging, health, and technology. Her current work focuses on the evaluation of the patient experience of brain health technology and on the integration of artificial intelligence and robotic technology for older adults. Dr. Eric Smith is professor of neurology at the University of Calgary, holds the endowed Kathy Taylor Chair in Vascular Dementia, and directs the Cognitive Neurosciences Clinic at Foothills Medical Center and the South Health Campus in Calgary. So we're very pleased to have you both on the line with us, and I'm just going to unmute Dr. Smith's line here, so just bear with me for one moment, and we will get underway. All right. Oops. All right, Dr. Smith, are you there?
I think so. I heard a couple of beeps, so I assume that I'm live. Thank you for the nice introduction, Jillian. And today's topic is COVID-19 infection in persons living with dementia. These are my disclosures. I've received consulting fees from Biogen and Alnylam Pharmaceuticals for research related to cerebral amyloid angiopathy, royalties from UpToDate for a chapter that I wrote on diagnosis of vascular dementia. My most important disclosure is that I am not an infectious disease expert. As you've heard, I'm a neurologist who directs a dementia clinic. I also work in the Calgary Stroke Program. So the information I'm presenting here about COVID-19 and SARS coronavirus 2 is based on my own reading and learning from the literature, synthesis of the literature, and matching it with my background knowledge in neurology and cognitive disorders. I will discuss what COVID-19 is, its clinical symptoms and course, interesting and emerging evidence that the virus has effects on the brain, potentially direct or indirect, by causing severe illness, and then transition to ethics of the response to the pandemic, where I will call in my co-presenter, Dr. Robillard. COVID-19 stands for Coronavirus Disease 2019. It is a new human disease caused by severe acute respiratory syndrome coronavirus 2, or SARS coronavirus 2. This is a single-strand RNA virus. The graphic here is a medical illustration from the Centers for Disease Control, or CDC, in the United States. It encodes 27 proteins, which makes it a relatively large virus. It's a member of the coronavirus family. Other coronaviruses that cause human illness cause a version of the common cold, like a mild upper respiratory tract infection. As you can see from the graphic, the virus appears as kind of a ball with these red, as shown here, these spikes sticking out from it. The coronavirus family of viruses was discovered by a woman scientist in 1965, June Almeida, and under electron microscopy you can see these little spikes sticking out from the virus, and she thought it looked like a crown, hence the name coronavirus. From corona in Latin is a crown. And these spike proteins that are sticking out play a key role in the biology of the virus, because these are the proteins that interact with human cells to allow the virus to be taken up by the cell. Then, like all viruses, the virus takes over cellular machinery to begin replicating itself, as well as expressing proteins that help it evade the immune system. The spike protein binds to angiotensin-converting enzyme 2 receptors, which are widely expressed in many tissues throughout the body, including respiratory endothelium, but also vascular endothelium throughout the body, including the cerebral vasculature. The SARS coronavirus 2 virus is closely related to previous viruses that arose through zoonotic transmission. So these are new human diseases that are felt to have arisen from contact between humans and coronaviruses that affect other species. The SARS coronavirus 2 shares the closest genetic similarity with coronaviruses found in bats. And although not unproven, the speculation is that the virus was transmitted from either a bat or from another species, like a palm civet in an animal food market in China. It is similar genetically to the SARS coronavirus 1, which caused the disease SARS. And in Canada, we had a very close experience with that virus, which was transmitted from Hong Kong to Toronto by a businessman that flew between the two cities and caused an outbreak centered in Ontario. Here I've created a table showing the name of the virus, the disease that it's caused, the number of cases, the case fatality rate, and the R naught, which I'll explain in a moment. So the SARS coronavirus had a case fatality of about 9.5%. Then there was an outbreak of the Middle Eastern Respiratory Syndrome coronavirus, or MERS, which had a smaller number of cases and caused a case fatality of 34.4%. And then finally, we have SARS coronavirus 2, which has caused COVID-19. And the difference between SARS coronavirus 2 and these previous viruses is that there has been global worldwide pandemic from SARS coronavirus 2, with, as of last time I checked, the Johns Hopkins website, more than 10 million cases as of yesterday morning, of which 4.9% of the documented cases are documented to have died. The true case fatality rate for SARS coronavirus 2 is uncertain, because in contrast to SARS and MERS, COVID-19 can be spread by persons when they either have minimal symptoms or asymptomatic. So the CDC now estimates that for every documented case of symptomatic infection, there may be as many as 10 times as many persons who have been exposed in the community for every documented case. That would mean the number of estimated cases worldwide could be as high as 100 million, but the case fatality would be lower, in the range of possibly 0.5 to 1%. By comparison, the case fatality rate from influenza virus is around 0.1%. So this is a virus that is 5 to 10 times more lethal than seasonal influenza, and because it's a new human disease that can cause severe illness, it's put incredible strain on our health systems, including intensive care beds and mechanical ventilators. The R0 value shown in the far right column represents the average number of persons that are infected by each person with the disease. So an R0 that is greater than 1 means that disease will spread, and it will spread exponentially. The R0 for SARS coronavirus 1 was 1.7. For MERS, it's actually less than 1. So an R0 less than 1 means that each person infects on average less than one other person, meaning that the disease will die out. SARS coronavirus 2 has the highest R0 of these diseases, with an R0 of 2 to 2.5. So in the absence of effective public health measures, each person with SARS coronavirus will on average affect 2 to 2.5 more people, leading to exponential spread. This graphic shows evidence on the transmissibility of SARS coronavirus 2. The graph on the left, on the y-axis, shows the proportion with positive cultures. So this is where live virus has been detected in the nasopharynx and be cultured. If there's live virus in the nasopharynx, the implication is that that patient is able to transmit live virus to other persons and infect them. On the x-axis is days after onset of symptoms. So as you can see, beginning at 4 days after onset of symptoms, essentially all of the patients in the study had positive viral cultures, and then that decays rapidly over time, such that by 10 to 12 days, live virus can no longer be cultured, and this is because the immune system has been activated and is killing the virus. On the graph on the right, we see the base log 10 RNA copies per milliliter. So this is the genetic material from the virus. And as you can see, the two graphs are anti-correlated. So in the beginning, in the first few days, there is lots of live virus in the nasopharynx, but very little genetic material. Then as the immune system begins killing the virus, you begin to see the genetic material of the RNA, presumably from lice virus, appearing in the nasopharynx. Our nasopharyngeal swabs to diagnose active infection are based on a genetic test. So looking at these two graphs explains why there can occasionally be false negative tests. For those early in the infection, there is only live virus without enough dead virus with genetic material to be captured by the assay. But the assay should turn positive in a few days as viral RNA material accumulates in the nasopharynx. It also explains why people can continue to test positive by the nasopharyngeal swab even after their immune system has cleared the virus. There'll be no active virus left, but there will still be genetic material from dead virus. So many public health authorities no longer require documentation of a negative test to document clearance and recovery from the virus, but will instead use a time frame from last symptoms. Not shown in this graph, but documented in individual cases, is that persons can also have culturable live virus around the time of symptom onset, or even up to a couple of days before symptom onset. And so this has been one of the most challenging aspects of controlling this virus, and what distinguishes it from SARS, which ultimately caused an outbreak but then died out and is no longer present in the population. This virus can transmit itself in people who have minimal symptoms, or possibly even before the first noticeable symptoms. And estimates vary, but the CDC now estimates that about half of the cases of viral infection are due to asymptomatic transmission. Given the amount of asymptomatic transmission, it's important to take population health measures to control the spread of the virus. This graph shows the daily number of new cases in Alberta from the Alberta government website. So the number of new cases is shown on the y-axis, and the date is on the x-axis. And as you can see, there's exponential growth of cases and a spike in mid to late April, followed by a declining number of new cases per month. Alberta has begun reopening non-essential businesses at the beginning of June, and so you can see on the right tail of this graph that we appear for now to still have a relatively low rate of new cases, suggesting that public health measures have been successful in aborting exponential spread of this virus. These public health measures include hand hygiene, physical distancing, wearing masks in public when not able to physical distance, working remotely, and banning large gatherings. These have been a tremendous stress on our patients and their care partners. And although not the focus of this talk, I think we do need to acknowledge the difficulties that have occurred in community care as well as institutional care for persons living with dementia. We have done a small qualitative interview study currently published on a preprint server and under review at a journal, where care partners and patients identified disruptions to their life along the themes of disruptions to access to medical care with the abrupt transition to telehealth and telemedicine, difficulty for persons living with dementia to remember to adhere to hygienic measures. There's been a loss of both formal support like day programs as well as informal support like visitation by friends and family members living outside the household. This is leading to anxiety and burnout among care partners. And several of the care partners reported that among the persons living with dementia, they had noticed an accelerated cognitive decline, which they attributed to the lack of intellectual stimulation and the effects of social isolation. I'll now talk about the virus and the clinical symptoms that it causes, focusing first on symptoms outside the brain and then the brain. This is a list of symptoms on the CDC website. So most commonly are fever and chills, although these are not universal, and some of the sickest patients with SARS coronavirus 2 do not mount a fever response. Cough, shortness of breath, fatigue, and muscle aches. These are all nonspecific symptoms that can be seen with any viral illness, including influenza. But as I will discuss on the next slide, these symptoms can be quite severe in the case of this virus. 10 to 20% will have headache, although to my knowledge this would be rare to be the sole presenting symptom. Some patients have loss of taste or smell, particularly, and then this can appear in the early stages of infection: sore throat, runny nose, nausea, vomiting, diarrhea. In 80% of cases, the infection will be mild and may appear identical to a routine common cold, or may have so few symptoms that patients may be described as polysymptomatic or even essentially asymptomatic, like no reasonable person would be able to recognize the symptoms for what they were. However, 14% will have more moderate symptoms with dyspnea and hypoxia. Many of these patients will require hospital care for supportive care and supplemental oxygen. And then about 5% have severe symptoms with respiratory failure, often requiring mechanical ventilation, cardiac, neurological, and renal complications, and requiring admission in an intensive care unit. And because this is a new human disease and can cause severe illness, it's putting a tremendous strain, if unchecked, on our intensive care resources. The primary site of injury in almost all patients is the lung, where it causes consolidation. In other words, the alveoli, the air-filled sacs of the lungs, become inflamed and fill up with fluid. On a chest X-ray or CT, one's seen signs that are similar to other causes of viral pneumonia, including ground glass opacities, which are the white areas in the lung here, as shown by the white arrow, a phenomenon called crazy paving, which is thickening of the septae that appears to makes the lung almost look like kind of a tile floor, and also these tubular increased size of segmental and subsegmental vessels. The upper lung fields are often involved in the posterior lung fields, which may partly explain why prone ventilation can be a useful technique in critically ill patients with low oxygen. The critical illness often occurs about a week after symptoms, and many of the patients will have initial viral symptoms followed by a honeymoon period with some recovery and then an abrupt worsening. The timing suggests that the worsening is due to a robust, indeed maybe overactive immune response with what's been termed a cytokine storm. Of the critically ill patients, 3/4 require intubation and mechanical ventilation. Mortality is high, even with modern intensive care, with the mortality approaching 40 to 50%. The average intensive care unit stay is 14 days, which is a long stay, and life-threatening complications are common, including hypotension, a prothrombotic state leading to deep venous thrombosis, thromboembolism or strokes, heart failure with reduced ejection fraction, and renal failure. And the burden of disease varies dramatically by age. Not so much the vulnerability to infection, which is more related to the closeness of human contact, and we've seen that places like meatpacking plants, long-term care facilities, and other areas where people in close contact are vulnerable to spread of the virus. But the case fatality rate varies quite dramatically. So these are pretty early data from early March, and I regret I couldn't find a better source, but I think we see the same pattern no matter in what care setting and what time it's been looked at, where you see that the case fatality rate is very low in children, probably not actually zero, but maybe 1 in 1,000 or less, and then begins rising in people in their 50s, 60s, and 70s, such that for older persons, the fatality rate may be as high as 10 to 15%, and even higher in older persons with comorbidities. Comorbidities that have been linked to higher case fatality rate include obesity, hypertension, and diabetes. There are treatments that are emerging, but none of them are effective enough to obviate the need for public health measures to control the virus, and there is currently no vaccine for this virus. The treatments with current support for randomized control trials are remdesivir, which is an antiviral drug. It's an analog of adenosine that gets incorporated into the viral RNA and prevents replication. In an RCT published in the New England Journal, it shortened time to recovery by 4 days in hospitalized patients, but was not effective if started in patients with the most severe illness who are already on a mechanical ventilator or receiving extracorporeal membrane oxygenation, ECMO. A smaller trial of hospitalized patients published in The Lancet showed a trend to improvement, again, if started early in the hospital course, but was not significant. Currently, remdesivir is still undergoing clinical trials in Canada, and it is not approved for use for COVID-19 by Health Canada, although it is under review. A recent study, not published either on a preprint server or in a medical journal yet, from the recovery trial, showed that dexamethasone, a steroid, reduced deaths by 1/3 in ventilated patients and 1/5 in patients on oxygen. Dexamethasone is already a Health Canada approved treatment used in different settings as an anti-inflammatory. And the panel from the NIH recently recommended that it would be reasonable to use this in patients who are hospitalized, including patients with severe illness. So it looks like we have some emerging treatments for patients with either moderate illness or moderate or severe illness. It is unknown whether there are any treatments that help improve recovery from mild illness or prevent progression from mild illness to moderate to severe illness. I'll now discuss the effects on the brain. This was the first retrospective cohort study of neurological signs and symptoms in hospitalized patients from a single center in Wuhan province in China. And they identified dizziness in 17%, headache in 13%, elevations of creatine kinase indicating muscle injury in 11%, impaired consciousness in 7.5%, anosmia in 5%, strokes in 3%, neuropathy in 2.3%, and single patients with ataxia and seizures. Subsequent to this, there have been 3 or 4 additional case series of patients from New York and from Italy, among others, describing, I think, a similar range of symptoms at similar frequency. Most of these symptoms are also symptoms that can be seen in other viral syndromes, although the frequency of these symptoms may be higher in hospitalized COVID-19 patients than in influenza patients. A prospective cohort study from France cataloged neurological signs in patients who were critically ill and admitted to the intensive care unit. They looked at 58 consecutive patients. Most had confusion. Many of the patients were mechanically ventilated and required sedation. So part of the confusion may be secondary to use of anesthetics and sedatives. Most patients had enhanced tendon reflexes and clonus. CSF was sampled in 7 to exclude encephalitis. A mild lymphocytic pleocytosis was common. 2 out of 7 had oligoclonal bands indicating increased antibody production in the CSF, but none of them were PCR positive for virus. MRI often showed leptomeningeal enhancement and sometimes small infarcts, and I'll show pictures of those in a moment. They only followed patients during their intensive care unit course, not after they left to go back to the medical ward or on discharge, but at time of discharge from the intensive care unit, they described that a third had a dysexecutive syndrome, indicating that even after coming off ventilator, patients still exhibited signs of encephalopathy or confusion. This is examples of the leptomeningeal enhancement, which is enhancement in the the linings of the brain, the leptomeninges, seen after contrast administration, and this was seen in 8 out of 13 patients that were imaged. Small brain infarcts were seen in 2 of the 13 patients. All had encephalopathy without focal signs. Some of them were small DWI lesions in the cortex. One of them was this subcortical infarct in the cerebellum, seen in the 2 panels at the bottom, that exhibited ADC restriction. And one possible mechanism for these infarcts could be related to viral infection of cerebral endothelium. However, infarcts related to hypotension or from cardiac emboli from cardiac effects of COVID-19 could be other possibilities. In 11 out of 11 patients that had perfusion imaging with MR, either arterial spin label imaging as shown in the top 3 panels A to C, or dynamic susceptibility contrast as shown in the bottom images D through F, they saw relative hypoperfusion of the frontal lobes, and the pathomechanism for that is not clear at this point. A case series of patients from a Boston hospital was published as a letter in the New England Journal a few weeks ago. They looked at 18 autopsies of patients who died of COVID-19. All had confusion or decreased arousal. There were hypoxic changes in all of the brains, and all the patients had been hypoxic prior to death as well. They detected low levels of viral RNA in 17 out of 18 patients in at least 1 tissue sample. However, the RNA levels were quite low, about 1 million-fold lower than in the lung. They did not see any evidence of viral proteins on immunohistochemistry, suggesting that there was no active viral replication in the tissues that they looked at, although they did not describe looking at the endothelium specifically. And so these findings suggest that there's either a low level of viral replication within the brain, or possibly that the low levels of genetic material might have been contamination from blood viremia. There is 1 publication so far on the symptoms and course of persons living with dementia who have contracted COVID-19 and been hospitalized. This is from a case series from a hospital in Italy. They found out of 627 consecutive patients, 82 had a history of dementia. Mortality was higher in the persons with dementia, 62.2% versus 26.2%, and it varied by stage of dementia. Those with clinical dementia rating, or CDR, scale score of 1.0, had a case fatality rate of 41.7%. For CDR 2.0, which is moderate dementia, it was 66.7%, and for CDR 3.0, it was 83.9%. What's not clear to me from the publication is the extent to which mortality was due to worse effects of the virus in these patients, or whether it was related to decisions around pursuing life-sustaining care in persons with pre-existing disabilities. And an important point is that the persons with history of dementia presented most often with delirium, 2/3 of them, or a decline in their cognitive and daily function, rather than fever, which was seen in slightly less than half, or cough, which was seen in only 13%. So that helps us as clinicians understand both what to look out for and also to be vigilant that a new onset delirium in a person living with dementia is probably an indication for testing for COVID-19. Unanswered questions about involvement of the brain included the effects on patients who are not hospitalized, whether there are central nervous system effects or cognitive effects, the long-term effects. The source of the viral RNA found in the brain is unclear, whether it's due to active replication of virus or simply some virus in the bloodstream. Whether the virus is replicating in brain endothelium, which expresses high levels of ACE2 receptors, is unclear, as well as whether this could be related to the small infarcts that can be seen in patients with COVID-19. The risk of stroke following COVID-19 is unclear. There was a case series of 5 young patients who presented with large artery stroke and were diagnosed with COVID-19. This is not something we've seen in Calgary, but we have to be vigilant about atypical neurological presentations of COVID-19. The long-term consequences, including on cognition, are not clear. And as well, we know that COVID-19 is more severe in persons with pre-existing conditions, but how that relates to their conditions or choices around their medical care is not clear. So in summary of this first part of the talk on clinical features of COVID-19, this is a new disease, a new human disease caused by the SARS coronavirus 2 that causes respiratory illness ranging from mild to severe with higher impact and higher mortality in the elderly. The impacts on other organs, including the brain, are just beginning to be understood. Only 5% develop critical illness, but it is severe and prolonged enough to put a strain on our health systems. And those with severe illness have a poor prognosis. About 50% will die even with full supportive care, and the neurologic prognosis in survivors is unclear. This new disease has the potential to overwhelm our existing intensive care resources, and this has led to difficult decisions in some settings when the number of patients needing intensive care exceeds the bed spaces and equipment that are available, including mechanical ventilators. So for example, in places like Wuhan province in China, northern Italy, Spain and New York, doctors have had to face difficult decisions, kind of like the following, where 4 patients may require mechanical ventilation to survive, but only 2 mechanical ventilators are left. And this has been called the toughest triage decision, allocating ventilators in a pandemic. So who would you ventilate? You know, an 82-year-old with a history of dementia and severe COVID-19, a 35-year-old EMT without health problems with severe COVID-19, an 82-year-old with a history of dementia, but a different indication for intensive care unit admission, such as a trauma, or an 82-year-old with a different comorbidity like stage 4 cancer. These are the kind of decisions that I didn't learn how to make in a medical school, that fortunately, to my knowledge, have not needed to be made in any jurisdiction in Canada, although I've been part of a team through Alberta Health Services to try to lay out some groundwork and aids to help make these decisions. I will now transition to my co-presenter, Dr. Julie Robillard, who is Assistant Professor of Neurology at UBC and the Associate Director of Neuroethics Canada, for some insight on population ethics and how to provide ethical care to a population during a pandemic. So I will let you take it away, Julie.
Great. Thank you, Eric. Am I coming through on the audio?
Yeah, we can hear you loud and clear.
Excellent. Thank you so much. Hello everyone, good morning, good afternoon for some of you. It's a pleasure to be here with you today and to add just a little bit to the really excellent overview that Eric provided about COVID-19 and dementia. And so for the next 10 minutes or so, I'm going to go over some of the key ethical issues that are arising during this pandemic. And I will also describe some principles that Eric and the team have put forward to inform resource allocation at this time. So I'd like to start with some acknowledgments for this portion of the webinar. First, Dr. John Fisk is my co-chair of the Ethical, Legal, and Social Implications Subcommittee of the Alzheimer's Society of Canada Task Force, and he's been an outstanding partner in leading this effort. I also, of course, want to acknowledge Dr. Smith for his impressive leadership with the piece that yielded the recommendations I'll be discussing, as well as Dr. Serge Gauthier, who, through his many leadership roles, has always been a strong supporter of the study of ethical issues in dementia research and care. I'm grateful to the Alzheimer's Society of Canada for organizing this today, as well as to the organizations that support my own aging-related work. So as Eric alluded to, there are ethical issues that are arising. The pandemic has led to the emergence of new ethical issues, but also to the re-emergence of well-known ethical issues, and this has occurred across four main themes. There are issues that are related to the person and the patient experience of both COVID and dementia. There are societal changes, there are research-related issues, and finally there are issues that affect the healthcare system more broadly. And just some examples of that we've uncovered through the task force. So related to the person, there's some harms related to limiting visits to hospitals and long-term care. Without visitors, sometimes we lose representation and advocacy for this patient group. There's been a small demand for medically assisted death due to COVID-19, something that requires some monitoring. There's been, we hear from care partners, the development of unhealthy coping habits and isolation. In terms of societal ethical issues, you may have heard about the proposal for immunity passport. That's certainly controversial. And there are, on a societal level, shifting perceptions about long-term care, which may have important repercussions down the line. In research, we've heard mostly in the United States some interventions taking place without informed consent, so some older adults being administered test drugs without a full knowledge of these research projects. There's been issues around pandemic exceptionalism, so should we study things differently because we're in a rush and this is an emergency? There's also pandemic exceptionalism around funding, so a lot of funding is diverted to this disease. There's questions around what's a fair profit to make from vaccines and therapies, and there's also questions around what's an appropriate ethical comparator for trials, so what do we use as a control essentially. And then finally, for the healthcare system more broadly, there's been some issues related to the use of at-home technology, so telecare, healthcare. These are not new technologies, but we're using them on a different scale now, and so we have to pay a little closer attention to how people benefit from those interventions, but also may be harmed. There's questions around experimental drug access, who gets a first go at those experimental drugs. And then finally, as Dr. Smith alluded to, there's important questions arising around resource allocation and triage, and that's the issue that I'll focus the remainder of this portion of the presentation on. So in tackling these issues, it can be helpful to remember that ethical frameworks in medicine shift during a public health crisis. So whereas traditionally we would uphold principles of biomedical ethics, and as a reminder for you, these are autonomy, beneficence, non-maleficence, and justice. During a pandemic, we shift and first need to consider public health ethics. So public health ethics is not a principlist approach, or it doesn't have four principles, but I've just organized it this way for the slide here. But essentially, public health ethics tells us that we must promote the collective good and benefit the population as a whole, and we also need to consider efficiency and equity when allocating resources. On some levels, those two systems overlap, and there's some principles that are very similar across the two frameworks, but overall, what we need to remember is that biomedical ethics in normal times would really focus on the person more, and public health ethics during crisis time really focus on the collective good. And so these principles are theoretical principles, and they make sense on paper, but sometimes it can be quite challenging to apply them to decision-making in the day-to-day and in the heat of the moment. And we've heard that these are unprecedented opportunities for decision-making, things that we did not learn about in school. So this is where it's very important to have careful planning going into this decision-making so that we can take the theory and really sort of apply it to real-world decision-making. And I put a quote there, although I'm not 100% sure that source is correct, so I got it on the internet, and that's not the most reliable. But before anything else, preparation is the key to success. And so with that in mind, with that phase of preparation in mind for the remainder of this portion of the webinar, I'll go over 7 guiding principles that are meant to inform the planning of resource allocation during this time of public health crisis. But the hope is that these principles are also applicable to eventual future public health crises, whether pandemics or otherwise. So let's start with the first principle. And these, of course, have to do with allocating resources in the context of the dementia community. And so the first principle is that decisions on access to life-saving resources for persons with dementia should be individualized. And while that sounds a little bit like we want to go back to biomedical ethics, what we're really trying to say here is that dementia is a syndrome with varying individual trajectories, and what is not appropriate in this context is blanket restrictions for persons with dementia. So essentially, a diagnosis of dementia shouldn't be an exclusion criteria for access to life-saving resources. Our second principle is that persons with dementia should be provided the opportunity to indicate their wishes regarding their goals of care. This is something I think probably most of us advocate within our practice or research. This is something that is ideally carried out ahead of time. I know this is something I've been very vocal about lately, but also on an ongoing basis. And what we've learned from research around wishes for care is that surrogate decision makers, next of kin, family members, spouses, are usually not great at guessing what the person concerned might have wanted. And so we have very good evidence that says this decision is very personal. And unless we are very vocal and we have very transparent and open conversations about our wishes, usually people around us don't have necessarily a great sense of what we would prefer. So with that in mind, every effort should be made to engage the person directly. We shouldn't assume that a diagnosis of dementia necessarily means the person doesn't have capacity to make decisions for their goals of care, and so that first effort should always be with the person directly. The third guiding principle states that decisions on resource allocation should respect the personhood of people with dementia. We should always strive to reduce stigma, promote equity, ideally by defining these guiding principles in advance, which is what we're trying to do here in this context here. And where possible, we should strive to engage persons with lived experience in developing these protocols, both on sort of the policy scale of things, but also within different institutions. I know in British Columbia, a lot of different institutions may have different protocols, and so where appropriate and where possible, we should always try to engage the persons with lived experience in this process. Principle number 4, decisions on access to resources should be based on expected survival, not presumptions about quality of life. Similar to the previous example I gave around stating one's wishes for the goals of care, predictions about quality of life are very difficult to make. They're often wrong. We often have difficulty projecting ourselves into the future given different health conditions or disabilities. And so this is essentially something we shouldn't do. We shouldn't try to predict what one's quality of life is. We don't have excellent tools to do that. We don't have a good sense of how to go about that, so we should really just avoid that process altogether and really focus on survival as a criteria. The fifth principle states that prognostication should be based on objective, validated assessments. This could be of different measures. It could be of frailty, of mortality, of functional stage. Ideally, these assessments are done rather rapidly at the bedside. Some examples that were put forward in the publication include the clinical frailty scale, which Dr. Ken Rockwood helped develop, or led the development of, I should say. We also have mortality risk models for persons with dementia. There's also the option of using dementia functional stage. So these should really be validated assessments that are used to make these decisions. The sixth principle states that the presence of mild cognitive impairment should not be used as a criterion for assessing suitability for life-saving care. Mild cognitive impairment is a risk factor for developing dementia, but many people with MCI remain stable and some even improve over time. MCI in no way implies disability, and many people with MCI can live independently. So that, similarly to the first principle around a diagnosis of dementia, presence of MCI shouldn't really factor in at all. And then finally, our seventh principle is that persons with dementia who are denied life-saving care are entitled to explanation and best alternative care. So as Dr. Smith mentioned, we haven't been in Canada, certainly in situations where these very difficult decisions are being made, but it may happen in the future. It's certainly happening in other countries, and where this happens, I think it's important that we're very transparent with our patient, with their family, and that's a way to foster trust moving forward. And of course, where appropriate, alternative care, of course, includes access to good quality palliative care where that's appropriate. So in terms of next steps and moving forward, these guiding principles will be only as useful as they are made available, and so we're working very hard with the Alzheimer's Society of Canada to disseminate these guiding principles and to raise awareness about them so that people are able to incorporate them in their protocol development and their decision making. If you're interested, there's a synopsis, a really well done synopsis available at the website for the Alzheimer's Society COVID-19 and Dementia Task Force, and there's a link in the slide, and I believe the slides are being made available. And Eric and colleagues also prepared a very nice publication, very clearly stated principles for the Canadian Geriatrics Journal, which will come out in September. I mentioned as one of the principles that an important piece of that puzzle is to engage persons with lived experience in providing feedback and sharing their needs and priorities at this time. And so we're also hoping to do that for these 7 principles beyond what we've already done with the task force, which does include some members with lived experience. So we're keen to hear back from the community and refine these principles in a way that aligns with their needs and values. And so with that, I will close my portion of the webinar. This is my email if you have any follow-up questions. And I believe Dr. Smith and I will be taking questions.
Wonderful. Thank you so much, Julie. And thank you to you as well, Eric. Insightful information you shared with today, and I know I certainly learned some new things as well. So, yes, we have some time to field some questions. I just want to remind our participants that there's 2 ways in which you can ask your question. You can ask over the phone by pressing *7 on your individual line, and that way you're no longer mute. Or if you prefer, you can type your question into the chat pod. I want to note that, again, only the presenters and I can see the question you've posted, so you do maintain a bit of anonymity there. If you do have a question for a specific presenter, because we have 2 today, then please include in your question, if you're writing it, to whom that individual you're directing the question to. And finally, before we get started, I also wanted to let you know that we'll be posting some poll questions, just like always, during the Q&A segment. I do invite all of you to take part in each one of those poll questions. Your answers are anonymous, but they help us tailor future webinars to meet your needs. So I'll jump into that first poll, and then we'll go into the questions. And this one is for you, Dr. Robillard, Julie. So you spoke about shifting ethical frameworks as they're not mutually exclusive. Do you have any comments on navigating between the 2?
That's a very good question. I think that most organizations that are sort of in the process of developing decision making would have some principles that they would uphold from one framework and one that they would uphold from another. So there's not necessarily a method or a protocol I can share with you. I think it sort of depends on the group that's making the decisions, the institutional values, and that's sort of usually what will guide which principle. It's just that in the public health crisis, a crisis time, we really shift towards the public good. But when those decisions are being made, we also always, of course, want to consider the individual. So I think a really nice example of how to navigate that is, so for example, if a decision is made to uphold the principle of maximum public good or collective good, to not offer life support to a given individual, in that case, we would go back to our principles of biomedical ethics and then support autonomy and beneficence in that decision and provide excellent palliative care and provide the patient with decision-making power around how that's going to unfold for them and things like that. So essentially it comes down to which framework we prioritize, but for each decision we can pull from these different principles. So it's a very complicated question.
Okay. So no new questions as of yet in the chat pod, but there was a question that came up in the registration that I'm hoping that you both may be able to comment on, and that's about the long-term care home sector, particularly in Canada. And so the question was, why was the long-term care home sector so disproportionately hardest hit in Canada compared to other countries? For example, 80% of our deaths nationally, close to 90% in Nova Scotia, whereas we know in Australia they've kept their long-term care home deaths minimal. Any insight into that particular situation from either of you?
Well, this is Eric. I can start, and I think it's deaths in long-term care homes I think have been quite high globally. There's certainly been variation, across countries. So, recent New York Times article that long-term care facility deaths account for 43% of the deaths in the United States. As mentioned, my understanding too is they account for a higher proportion of the deaths in Canada. What part of the reason may be differential vulnerability among the long-term care homes to spread infection, but of course you have to think about the denominator part too. It may also be that some countries may have a similar death rates in long-term care facilities, but might be better at suppressing the deaths outside those facilities, thereby leading to a higher ratio, which I think is maybe part of the reason for a higher proportion in Canada than the United States, for example, where we know that, if you remember the curve I showed of cases in Alberta going up and then going down, which is also true to varying degrees across all Canadian provinces. In contrast, in the United States, that's not what was seen. There was a peak, a decline, and now a rise again, such they have more new cases per day now than they did in the peak in April. So I think that's part of it. Long-term care homes certainly have been quite vulnerable to spread of the virus because you have many people living together, require care from others for good hygiene, sometimes more than one person in a room. I think we're just beginning to understand some of the tragedy that's unfolded there. And I believe part of the problem may have been that there was a focus on acute care hospitals in terms of providing personal protective equipment, but also importantly the training needed to use it, and that long-term care homes may have been left out in the beginning that led to an explosion of the virus. Full disclosure too, we considered expanding a portion of this webinar to focus on what was happening in long-term care, and ultimately decided that was a topic that was so big from a public health, from a science, and from an ethical perspective that we couldn't do it service while also covering these other topics. So I'm hoping that the Alzheimer's Society will have a series of webinars on long-term care, including trying to understand what happened, how to advocate for change, for people's protection, and also to give kind of practical advice about how to manage that sector. So those are my thoughts on the tragedy in the long-term care homes, and I'll turn it over to Julie if she has other insight to add.
No, I think that's an excellent overview, and certainly there's increasing attention being paid to this very problem. So hopefully we'll have some clear answers very soon.
Okay, thank you. Okay, so moving forward to another question. This participant says, I'm so interested in the decision regarding prioritizing minimizing mortality versus quality of life. Can you speak to why that is? So I think, Julie, you'll probably take that on.
Yeah, I can certainly start. So I think the point that we're trying to make is that we need, when making decisions about resource allocation, we need to stick to things that we can objectively measure, or measure as objectively as possible. And mortality just lends itself to that type of assessment better than quality of life. And the sort of very famous examples around how bad we are at predicting quality of life looks at the two extremes of that prediction. So, for example, lottery winners, people expect lottery winners are going to have a great life and they're going to be very happy. And then we find, of course, in studying them that that's not the case at all. And at the other end of that spectrum, people who have spinal cord injury, for example, who become paraplegic or quadriplegic, collectively, we always think, oh, that's horrible, and they'll have a horrible quality of life. And again, evidence suggests that that's not the case. So essentially what these various pieces of evidence demonstrate is that we really don't have a good way to predict what one's quality of life is going to be like. And so we shouldn't say, well, this person has dementia, so they're not, I don't think they're going to have very good quality of life, even if they survive this COVID disease. So those kinds of judgments essentially are inappropriate. So we need to focus on metrics like mortality because we have more objective assessments for them. I don't know if Eric wants to add anything to that. You may have some insights here.
Yeah, I'll make a comment too. I think there is broad agreement across people in Canada and globally. That let's say a 49-year-old with myopia who needs a ventilator, and a 25-year-old, with their whole life ahead of them. Most people would agree that you want to allocate the resources to those who would derive the maximum benefit from them. And I would agree with that, even though I'm the 49-year-old with myopia, right? Like I guess sitting here in the office today, at least I would feel that if it came down to it, that a younger person should have a chance for a ventilator. I think what we include in the principles, though, and Julie so nicely articulated, is that when you go beyond years of life but start making judgments about the value of one's life, this is where it becomes, it's against most of the ethical principles, from experts like Julie and others that I have read, for all of the reasons she describes, right? That people can have good quality of life with a whole range of different health problems or disabilities. And so it's not disabilities or their function, but rather an outlook for years of life remaining that would be something that should drive a decision of allocating a ventilator to one out of two persons, if such a decision needed to be made. And of course, knock on wood, we're not aware that such decisions have needed to be made in Canada, and we hope they don't. But there's been planning for contingencies of like what happens if there's another outbreak and it needs to be enacted. So that's why this work has been important.
Wonderful. Thank you both. Well, I think we'll leave it there today. I do want to say thank you to our presenters, Dr. Julie Robillard and Dr. Eric Smith. Pleasure hearing from you, and such a timely topic, obviously, so thank you for sharing your insight and experience and perspective with us. Thank you again to all of our participants for attending today during this very busy time and for your questions. Much appreciated. And again, just as importantly, I thank you for taking the time out of your very busy day. We're currently working on a date for our next webinar series. We just got it booked, so it's going to be July 28th, and we're going to be looking at age-related stigma, so stay tuned for more information to come your way over the next coming weeks about that. And Dr. Robillard or Dr. Smith, any final words before we close today?
Thank you so much to everyone who attended.
Wonderful.
Thank you.
Thanks again, and I want to wish you all of your families good health, and once again, thank you for your dedication to those we serve, particularly during this difficult time. And let me be the first to wish you all a very happy Canada Day as well. So a little bit early, but something to celebrate. So thanks all. Have a good rest of your day. Until next time, take care. Bye-bye.